excuse me there. And sure enough, these are my historic PSA numbers. On June 27th, 2000, 1 week after my 45th birthday, I had my first PSA test. It was a 1.3. In hindsight, that's kind of a lot for a 45-year-old. But over time, it slowly increased, and I got to learn what PSA actually was. That it really is not really prostate, not cancer specific, but can mean a lot of different things. Just that my PSA was elevated, but every year I had one done, it kept on going up and up and up. But at the time, all that you always heard about was a PSA of 4 was the warning. So all that time, all those up through 2000, 2011, I was really unconcerned, except that the numbers kept going up. PSA doubling time at first was smooth. It increased going up. And when I hit 4.2, my urologist and I discussed it. We wanted to do one more test before we started down the biopsy route. And so we waited. And in February of 2012, it was still 4. So we decided to go ahead, schedule a biopsy. At the time, I knew nothing about blind biopsies or MRI guided biopsies. I was new at this, but I knew that I had to look into it. So in April 2012, I had a transrectal ultrasound needle biopsy. They weren't doing transperineals yet back then, I don't think. I hadn't heard about it. I had no idea what to expect. No social media, no in-person virtual support groups, didn't know blind versus MRI guided. Information wasn't out there like it is today. Today, guys have at their fingertips information. But that was a photo that I took in the doctor's office there of this little machine. I don't even know what it was, but I knew that I was not going to enjoy this. That was for sure. And those were those 10 little vials on the countertop there. He was going to put the biopsy tissues. The results of that was that I had 10 cores taken, 5 were benign, and 5 were a 6-3 plus 3. A few weeks or a few months later, we requested a second opinion from Johns Hopkins. Had Dr. Epstein look at those, and he confirmed the 3 plus 3. So, and this is where my urologist and I got into good discussions. He recommended surgery. I find out years later that many urologists recommend surgery, but he didn't have a good reason as to why. And I'm not one to have appendages cut off without knowing why. My wife expressed that she wanted me to have surgery. She said she couldn't stand the thought of a cancer being in my body, but for me, that was not quite a good enough reason. So everything that I have read indicated that with my numbers, active surveillance was the right course of action. But no one told me that there were things you shouldn't do which might increase PSA levels. Even though my biopsy was a 3 plus 3, there are things that can cause an elevated PSA, urinary tract infection, prostatitis, sex prior to PSA test, exercise vigorously, riding a bicycle, and more. So that knowledge waited a few months, repeat PSA test as part of the process, and they dropped back down again. Now I still had a 3 plus 3. My urologist still recommended surgery, but the literature that I read indicated that active surveillance was the right course of action.
Ryan, when you were doing your first test there, did you work with free PSA?
I did not. At the time, I didn't know about that. Again, I learned a lot later. I knew about PSA doubling time. I knew about PSA velocity, but I did not yet know about percent free PSA. That would have been helpful to have known that back then, but that was not quite in my vocabulary yet. I did have a biomarker test later, an Oncotype DX, with an intermediate result. It had a 64% likelihood of favorable pathology. Again, that was sort of slightly better than in between, but it wasn't enough for me to continue down that active surveillance path. Bone CT scans, no evidence of metastasis, and since PSMA PET scans didn't come out until, I think, 2020, those weren't available yet. And for the other scans like Councilman and those other pre-PSMA tests, those weren't typically given for initial diagnosis unless there was some suspicion of metastasis. So I didn't have any type of PET scan at that time. As I said there, no PET scans back then anyway. So I chose to stay on active surveillance. I think I had tracked it for so long. I wasn't scared or shocked or intimidated. I wasn't thinking about death or not seeing my grandkids get married or something. To me, it was like other blood work tests that you monitor for life-threatening conditions. It could be cardiovascular things or whatever. Simply something that needed to be monitored. And then, if medically necessary, to have treatments. I still have the journal that I maintained throughout this journey. And one of my earliest comments to my urologist was, okay, let's slow down and figure this out. I got questions to ask you before you cut anything out of me or do radiation or inject chemicals. And so I was in a learning mode. I wanted to learn all that I could about this disease to make the right decision. And that set the tone for our discussions, which started me on my active surveillance that lasted for 9 years. I tracked all my numbers. I understood that a 3 + 3 may or may not may or may not grow. That was okay. We did, later on, I learned about percent-free PSA. So we started tracking those later. As long as the PSA was between 4 and 10, percent-free PSA means something. So later on in my journey, we did do those. But at the time, PSA doubling time, and it jumped up and down. About 2 years later, in 2014, it had another blind biopsy, another Gleason 3 + 3. But I was having some issues. And I can see this from this chart because in 2014, July, I started tamsulosin. So I know that I was having urinary issues. In the back of my mind, something's going wrong, something's going on here. My third biopsy was an MRI-guided biopsy. It was a PIRADS 3, which is in between of the PIRADS. It's not 1 or 2, it's not 4 or 5. It could or couldn't be. It was still a 3 + 3 Gleason, so the biopsy wasn't that good. But things kept on getting worse urinary-wise because my urologist then prescribed finasteride. So I was on both tamsulosin and finasteride at the same time. Now, as you all know, with finasteride, it works by shrinking the prostate. But what that does also is it artificially reduces the PSA number. So you always, from that point on, have to multiply your PSA result by some factor. And we were assuming a 50% reduction, so it would have to double the number. So my next PSA in April 2017 was a 2.7, which accounting for finasteride would be a 5.4. And that left us some concern. So any questions? Okay, so we're doing good. Any more questions on here? He doesn't do other links. Okay.
What was the size of your prostate? Did you have it at that time?
That I don't remember. I'd have to look at those reports. I just don't recall. But I recall that it was not enlarged. That there was no suspicion of BPH or an enlarged prostate. That was not something that ever came up. But my PSA kept rising. So where it shows 5.4 in November 2017, that was just a repeat another 2.7. But then in May 2018, it was a 5.8, which is, or a 2.9. You have to double it, 5.8. And so I knew things were not looking good. And then a 3.6 PSA is a 7.2, and again, I'm starting to get worried there. But my third biopsy there, this was MRI guided. My second MRI guided biopsy was a 3 + 4 it wasn't a real small amount of 3, but again, it was at that point that I started getting serious about my decisions, and I really had to start somewhere around 2019. I got serious about researching treatments because the numbers kept on going up. I did eventually, see if I can advance this page here. There you go. Yes, there were some numbers to track, which I did. Once I started having MRIs, I could then know my prostate volume and I could track my PSA density, and it was never a problem. I didn't have an enlarged prostate. There were genetic tests I could do, but I didn't do those until later. And I didn't have any of the gene mutations related to prostate cancer. My biomarker genomic tests, I had, as I said, the Oncotype DX test when I first was diagnosed. Later on, I had a Prolaris test, and that test let me know that it was time to go on for treatment. And that's a good thing that I found about active surveillance, is that it gives you time. I'm not the type to worry about things unless things are serious. And so for all those years, 2012 through 2018, I really didn't take this seriously. Maybe I should have a little more, but I have read studies. I wanted to learn more as much as I can. Studies show that treatment-related regret is greatest among those who have not had time to understand treatments, side effects, or set expectations. And so I wanted to learn all that I can. I asked my urologist tons of questions, but at some point a decision had to be made, and it was mine to do that. He can make recommendations. My wife could tell me her wishes, but it was my choice because I was going to have to live through this. So as for the biomarker tests, there are tons of those these days. There are liquid biopsy tests. I know one guy, due to surgery he had decades ago, he can't have a tissue biopsy. It just is not, it was something that happened to him years ago. So he does a Foundation 1 liquid biopsy or a PCA3 biopsy or a PSC type of PSA test, so there are choices out there that you have. If I know one old gentleman, he's old, he has dementia, and his family does not want him to go through a tissue biopsy. They will do a urine test, and he may or may not do a blood test, I'm not sure. But again, there are options out there, and that's what's great about today, a person choosing. So during those 9 years, what I committed to, that should even though things are different today, back then, people with a low-grade Gleason 7 did not choose active surveillance. That was not generally the way it was. But what I committed to was should my PSA ever reach 10, or my Gleason reach 7, or a biomarker test be unfavorable, then I would seek active treatment. Again, this was just time that it gave me in order to research things out. Let's see there. Okay. So what I need to go up front. Yeah. Okay. So what happened at this point, after I had that Gleason 3+4, we waited some time. I still was not prepared to pull a trigger yet, and we had that tissue sent out for a second opinion, and the second opinion came back a 4+3. So that left me in a fix. I realized that Gleason scores were a pathologist's educated, experienced opinion as to what he sees under a microscope. But different pathologists can see different things. I was at a Zoom meeting just the other day where this guy was concerned because he had had 2 second opinions on a biopsy. The first one came out at Gleason 8, the second one at Gleason 9, and the third one at Gleason 10. And so what I decided back then was, with my second opinion, whichever one came back the highest, I was going to go with. I didn't want to undertreat. I would prefer to overtreat slightly. So if I had the 3+4, if the second opinion came back a 3+3, I was still going to go with the 3+4. If it came back a 4+3, I was going to go with the 4+3. And sure enough, it did. With that 4+3, then that set the tone for my treatments that were going to happen. And so at that point, I'm nearing the end of active surveillance. I'm having to make a decision. Data I'm reading indicates that with localized prostate cancer, no matter what I chose, statistically equivalent outcomes were going to happen, and that the choice of therapy involves trade-offs between benefits and harms of treatments. And in my case, I made it clear to my urologist that I wanted to balance survival, of course, with quality of life, along with possible treatments in the future if needed as medical treatments progress. So I wanted the least side effects possible. And again, my urologist really worked with me on this. So I had those years to review literature, to become what I call a student of prostate cancer. My urologist, he gave me referrals to anyone I asked for. I wanted to learn about focal therapy. He referred me to the experts for laser ablation, cryo, and HIFU. As it turns out that I had 2 lesions, one on either side of my prostate. So everybody I talked to said I was not a candidate back then for focal therapy. I talked to internal radiation specialists, both low dose and high dose. The reason I didn't take that, I knew 3 guys from my high school, who had prostate cancer, who had brachytherapy. All of them had terrible issues. Now, at the time, I didn't ask, who is your doctor, what's your hospital, all these things. I just know that they told me that they were having urinary issues and ED issues, and people they knew who had brachytherapy had the same thing. And so given that, I ruled out brachytherapy. SBRT, I talked to a doctor about CyberKnife and TrueBeam. The CyberKnife, and we're talking 2020, early 2020 right now. The CyberKnife guy and I just didn't click. We had different personalities, and I mean, it may have been the best thing since sliced bread, I don't know, but he and I just didn't click. I couldn't get him to answer questions about side effects and probabilities and things, and so we just didn't work out. I saw the IMRT doctor next, and TrueBeam followed, and then proton. Proton had this characteristic called the Bragg peak, which intrigued me. Me being a scientist, a retired computer scientist, things that are technical intrigue me. And I did the Bragg peak about how the proton particle could be controlled. Little to no scatter, little to no entry dose, little to no exit dose. That really attracted me. But I still kept tracking PSA numbers and kept things going while I was research. Ultimately, a number of factors. That biopsy, 3+4, the Polaris molecular score was unfavorable intermediate, and in it, the recommendation was this patient has exceeded the threshold for active surveillance. That was the kick I needed to get moving. PSA was not quite 10, but those other 2 conditions that I had committed to had been set. And that second opinion increased that to a 4+3. So those things, I was ready then to move off of active surveillance. The moment that I chose radiation, I haven't seen my urologist since. That was, I moved on to radiation oncologist and on to medical oncologist. But what I did was, had a really hard time. So as everybody does, make a decision, which way to go, radiation, surgery. And being a retired computer scientist, I tend to quantify things. If I want to buy a new house, I make a list of what I want, what I don't want. If I'm going to buy a new car, I make a list of what I want, what I don't want. I make a list of numbers, and I quantify things. And so for prostate cancer treatment, I put together a spreadsheet and listed all treatment options from what I discussed. So I ruled out focal therapy. I had ruled out brachytherapy. I had ruled out SBRT, so that really left IMRT, proton, and surgery on the table. So with each treatment option, I really had an introspection, discussion with myself, thinking, what side effects would I least like to deal with, and what side effects would I not care about, really don't matter. ED was big. Continence was big. Incontinence was big. There are things that are major factors. Some things are less. If you happen to have a tanning or redness where the radiation hits. That's not a big deal on the grand scheme of things. And so I listed all these things that I prefer. And then I did the same thing, and I listed what was possible and probable side effects of all types of treatments. Surgery, radiation, including IMRT and proton, both. And I scored them. And the one with the lowest score ranked the best. I then took that list and narrowed it down. For instance, with radiation, you can have rectal issues, proctitis, rectal burns, all sorts of things like that. And you can prevent those with a rectal spacer. Your full bladder empty bowel routine will help some against some types of side effects. And so listing down the side effects, by not radiating the penile bulb, you can minimize the chance for ED. Lots of things like that. So after having that narrowed down list based upon the prevention techniques available, I then compared my two lists, my quality of life priorities based upon my introspection, and this final score with these treatment options that I had just listed. And the scores that were closest was my matching, was my choice. Number 1 was proton. Number 2 was IMRT. Number 3 was SBRT, and surgery ranked last. And so I went to my urologist and I said, here's what I've chosen. I've chosen proton. And there is a proton therapy center just a 40-minute drive south of where I am. I live just outside Dayton, about 8 miles east of Dayton. UC is right down I-75 from here in Liberty Township. I had some tests to do prior to the start of treatment. PSA, another PSA. Every time, at the time that I moved off of active surveillance, at that threshold, every time I have a PSA test, there's a testosterone test there too. So they wanted baseline, DEXA scan, CBC, CMP. Once again, PSMA scans weren't out until December 2020. The gallium-68 PSMA PET scan, and even though it was approved, logistically, they couldn't get it out of California, where it was approved at UCLA and UCSF because the half-life of gallium is only 56 minutes. And so there was no way logistically to transport it to Ohio. That wasn't possible. And I wasn't going to pay money to go out to California to get that done. And so making the decision for proton, the upgraded Gleason to a 4+3, we simply had to add 6 months of Eligard to that. And that was the end of my active surveillance. This shows what happened immediately after, as I started treatments. The Eligard dropped my PSA down to almost nothing. And the rest of this is part of another presentation. But everything worked the way it should. The only change I would make in my active surveillance is I probably would have been treated a year earlier. After that upgrade of the Gleason, I wasn't quite prepared for that. And I probably should have had treatments in early 2020 rather than waiting to early 2021. That was something on my part. One of the things that caused me to wait, though, was when I did decide on my treatment, the radiation oncologist who I had down at UC Cincinnati had never used SpaceOAR before. He'd always used endorectal balloons. And I respectively declined that. I read about those, and I didn't want that done for every treatment. And so what I did is, it turns out at the time that the manufacturer of SpaceOAR, Boston Scientific, had this program where, as a patient, they had a patient outreach program. And I contacted them, and they gave you one free consultation. And so I got to learn about SpaceOAR directly from them. I went to my radiation oncologist about that. He still had never done it before. And so I reached out one more time to Boston Scientific to put them in contact with my radiation oncologist and to get SpaceOAR out there. And they did. And so that took time. We also had to find someone to inject it. because he hadn't done it before. So we found somebody else in the urology department to inject that. And what happened was I changed plans again. Right before my appointment to inject the spacer, I found out that Boston Scientific had a brand new spacer product called Spacer View. Typically with regular spacer hydrogel, it does provide that space, but it doesn't show it very well on a CT scan, and they can't see it very well. And what Spacer View does is they put a 1% iodine solution into the spacer product, which makes it show up perfectly clear on a CT scan. And during the CT sim, it's there, and during the treatments, it's there with each of the quick CTs before each radiation. And so, again, so we did a lot in that transition period between when my active surveillance ended and actually kicking off my radiation treatments. There was a lot of discussion, a lot of changes that went on there, and but everything went very, very well. The right side of that screen about my proton treatments and what's happened after that, I've got part of another presentation that I have. I had 28 fractions of proton radiation, 2.5 grays per fraction. And I've got a few slides to summarize here. What I've learned is that urologists, radiation oncologists, and medical oncologists don't know everything. I mean, they're just like you and me. They have jobs. They have an aptitude for this, like you and I did with our jobs. They've got a passion for it, like you and I did for our jobs, but they don't know everything. I think I've learned more listening to you guys in the different support groups than I did from my doctors, because by listening to 10 of you, I get to hear what 10 other doctors told you. It's fantastic. But with doctors, we're one of hundreds of their patients, maybe dozens, I don't know. Outside of work, they have families, lives to live, vacations to take, student loans. They're just like the rest of us, but they're in an occupation. Self-advocacy and shared decision-making. I had to open up a conversation between myself and my doctors to get what I thought was the best diagnostics and therapies. I'm not the type to leave my life in their hands. Some guys are, I'm not. I've got to have a say-so and have something involved in this in order for me to do it. And so I became a student of prostate cancer. I've read so much, so many webinars and seminars and PCRI and PCF and ANCAN and this Reluctant Brotherhood and all these groups and the CSC in Cincinnati. It's been fantastic knowledge building. If the numbers, I like numbers. What I found early is that everything about prostate cancer is about numbers. You got PSA, you got percent-free PSA, PSA density, PSA doubling time, PSA velocity, all numbers. With MRIs, you got PIRAD scores, more numbers. With biopsies, you got Gleason scores, and percent threes and percent fours. It is just fantastic in what the numbers are. It's just incredible. And me, being a retired computer scientist, I eat, live, and breathe numbers, even in retirement. And so with active surveillance, if the numbers and the diagnosis say it's correct, then choose that. If they don't, don't. And that was a mantra that I lived by at the time. It's now been 25 years since my first PSA test, 13 years since I was diagnosed with prostate cancer in 2012 and started active surveillance, and 4 years since I completed proton radiation treatments, and that was through April and May of 2021. And today, except for the knowledge that I've gained, I'm just monitoring PSA numbers and testosterone numbers still, like I do for cholesterol, blood pressure, and things like that. Active surveillance buys time. It bought me time. Early and annual PSA testing is the key. What I tell new patients, first of all, don't panic. There is big C cancer and little c prostate cancer. Let the numbers guide you there. PSA testing isn't cancer specific. If you got a high elevated PSA, it's like a check engine light in a car. Something's wrong and you got to look further. Monitor all the PSA numbers, as somebody indicated before. If I'd known about percent-free PSA back then, I would track that too. Have a 3T MRI before the guided biopsy. Get second opinions on anything that requires an interpretation. Now, PSA is a number, boom. But in MRI, they have to read and interpret a scan, get a second opinion. Biopsy, they have to get the tissues and interpret the biopsy, get a second opinion, because they're human beings. These days, for 3+3 and some 3+4, active surveillance may be the right call. But develop a plan. Don't just say I'm active surveillance and not check your PSA again, feeling happy. Just dumb and happy. Just get it every 2 to 4 times a year. Get your PSA tested. Get the biomarker tests, the genomic tests. Don't confuse watchful waiting and active surveillance. I hear those terms used interchangeably. Active surveillance, you're doing active PSAs, periodic MRIs, periodic biopsies. You're really checking things. Watchful waiting is usually used for men who are too old or too sick to be going through all that. And you kind of just watch and wait and make sure nothing bad happens. If it does, then you act. But the two are a little bit different. Diet, exercise are important. They say a heart-healthy diet is a prostate-healthy diet. Don't forget diet, exercise. Prostate cancer, for me, was more of a problem to solve than a death sentence. It was something that I had to figure out and solve, and I didn't let fear and emotions guide my treatment decisions. The numbers guided me, and we acted appropriately. Active surveillance isn't anti-treatment. It's anti-unnecessary treatment. You follow it, and if it becomes medically necessary, you've been tracking it so closely that you can treat it as soon as something changes. And that's what's key. Catch it early. Learn all you can about the cancer, diagnosis, treatment, side effects, outcomes. Attend these support groups. Like I said, I attend 3 support groups in our local area and probably 3 or 4 online. I know my wife, when I tell her I'm going to attend a Zoom meeting tonight, she just rolls her eyes because she knows it's going to be prostate cancer related. Again, it's never can learn too much because some guys are much further along in aggressiveness than I am. And I want to know what I might need to do should something bad happen with my numbers. I just don't know. But early and annual PSA testing is key. As it turns out, 3 years after I was diagnosed with prostate cancer, I was mayor of my city. And sometimes you have to use the bully pulpit that you have. And so I had this proclamation issued to recognize Prostate Cancer Awareness Month. At the time, this was August 2015. Prostate Cancer Awareness was in September, I believe it was. But at the time, I think by then, more and more people knew I had prostate cancer. At first, nobody but my family and even my close friends didn't know. But as time went on and more people knew, even my wife, some of her friends, their husbands had prostate cancer. And so I felt more free to go out and have an awareness proclamation issued to bring awareness to my community about prostate cancer. I mentioned earlier how it's not a death sentence. Be sure to catch it early. Prostate cancer is the most diagnosed cancer in men, but in the mortality rate, it's near the bottom. And I put this chart together late last year. I had told my brothers about my prostate cancer years ago. They didn't take it seriously. But in August of last year, the first week of August of last year, my older brother was diagnosed with pancreatic cancer. And so I was curious, comparing pancreatic cancer mortality rate to prostate cancer. And so that they had data, estimated 2024 data based upon 2023 actuals. And my brother was in a bad condition. He was diagnosed in the first week in August of 2024, and he died October 24th. So he didn't last long. Pancreatic cancer is a death sentence practically. Prostate cancer, in comparison, very, very good. It's very, very, very survivable. Not good, but survivable. And then finally, my last slide here. Last year, I was, with all this news, if you read recently, Ryan Sandberg, baseball player from way back, passed away recently. I was curious, though, as to how many celebrities, and this I did last year, actually, how many, I hear so much from guys saying they never heard about prostate cancer, they never heard about PSA testing, all this kind of stuff. So I spent about an hour looking online about celebrities who either diagnosed with or died of prostate cancer, and just in 1 hour, this list. And all of us have heard of many or most of these lists. But despite all the media attention and given to these celebrities and their diagnoses and some their deaths, most men say they never heard about prostate cancer and never get PSA tested. I don't understand that. But it's every sports field, politicians, everybody. It's incredible. And there's probably more since I did this. But anyhow, this is the last slide here. And if anybody has any questions as to why I did something that I did during my treatments, feel free, or something I might have done differently. Feel free to step in. None whatsoever. So what's happened recently, there have been 2 studies. One, and you look these up, one was called the COMPARE study, COMPPARE. You know what that stands for, I don't recall. And the other is called it's spelled PARTIQOL, PARTIQOL. Both of those, I believe they're still ongoing, but they're comparing photon, which is your regular IMRT, photon to proton. Now, the COMPARE study is still going, but they did give preliminary results a few months ago. And what they found was that the side effect profile comparing IMRT to proton was statistically equivalent. And since that's happened, there's been a lot of insurance companies hesitant to go with proton that's going to cost three to 4 times as much than regular IMRT. I mean, mine, I believe, if I recall from my records, was $215,000, just the treatments themselves, not any consultations or any blood work or whatever.
They're fixing that right now. They've already putting together a 2-room proton machine. I think it's at Stanford.
Yeah.
They've got it way down in size. They figure within about 3 or 4 years, it's going to be just as cheap as building the other style. So
yeah, that is the goal. From what I've heard, is if they can get enough of them done, it'll drive down the cost. But right now, there's only 46 active proton centers in the U.S. compared to a zillion IMRT photon centers. And so the numbers have to be there. And so you need the referrals, and then you need the centers that are already doing them. But again, I'm surprised that UC, their Liberty Township, since they already have the center there and are doing them. But you said this is Medicare, actually, that back to the way you said, Bill. Was that the case?
Yes.
Yes. Now, something that I did, and my radiation oncologist told me that this would, if there was any question about doing it, this would help scoot it through, was to sign up for a clinical trial. And so at the time, and I forget which one it was, there was a clinical trial at the time comparing photon to proton. Now, as it turns out, I didn't sign up for that. What I wound up signing up for was to have all the information for the next 10 years go into a registry that some university is out there collecting on proton treatments on any types of cancer. And the fact that I signed up for that, he said even that would get rid of any question from any insurance company pushing back against covering me. And so I really have not looked into it since then as to maybe that was the reason I got through so quickly. But I really had a good relationship between my urologist and myself, my RO and myself, and my MO, so that we can discuss things openly and find some ways to grease the skids, so to speak, so that things went through well. But yeah, I had no issues at all with UC in doing that.
Okay, and one of the things about the Westchester site is the fact that Children's was the one that got that going, because there's definitely big benefits for treating cancer in children with that, as far as the accuracy and the lower side effects in children. And UC kind of tied in with that to get the capability also.
Yeah, so that was one thing that helped decide me proton. I understood it, even though there weren't trials done yet to compare photon and proton, the word was floating around that they were basically equivalent. But to me, that didn't make sense. If they can use proton therapy in a child to zap a grape-sized tumor in the middle of his brain and not touch any brain tissue, if you can use proton for liver cancer and other cancers without side effects, why can't you hit a walnut-sized gland in the middle of somebody's body? I mean, the laws of physics don't change. It should still work. Now, there is a Dr. Rossi out of California. He spoke at the 2023 mid-year PCRI conference, and one of the Q&A session, Dr. Moyad asked him a question about how much of these treatments, how much experience do you as a doctor need in order to do it right? And Dr. Rossi made reference, I think it was to treatments it may have been Penn State it was, where they had done the calculations wrong and were getting outcomes not as good as other facilities were. So from what I understand, with proton radiation, there was a very complex calculation that has to be done in order to get it right. And, I'm hoping that all of these centers that are in these two clinical trials are all doing the calculation exactly the same and exactly right. Or if they get it a bit wrong, are they going to have side effects similar to photon? I don't know. I just know that when I looked into UC and their children's hospital right there, I believe that UC is a teaching hospital. I know for sure it's a research hospital. They do all these things. They're very successful. And that helped build me confidence that they were the right choice for me. I asked more questions. Prostatectomy and radiation are a lot different. If you have a prostatectomy, you want a doctor who's done a zillion robotic surgeries. But I can tell you that during my radiation treatments, I never saw my radiation oncologist in that treatment room one time. Now, every Friday, I met with him to discuss that week's treatments and what's coming up next week. But for my 28 treatments, he was never in that radiation room one time. The radiation technicians were in there doing the machines and treating me. And so some of the questions that I asked my radiation oncologist were, how experienced is your team? The medical physicist who's going to be shaping the beam with the computerized system, how good is he? With the dosimetrist who's going to be calculating the biometric effective dose for my body, how good is that person? I wanted to know behind the scenes, how was the radiation oncologist like a team manager, a football coach? He's not the quarterback throwing the ball. He's not the receiver catching the ball. He knows the plays, but he's not the one doing it. I wanted to know how good were the guys doing it. And I had them draw me pictures. I had them draw me a picture of how much radiation would hit my prostate versus my other nearby organs if I were doing IMRT, and draw me another one, how it would look doing proton. And those two drawings showed me right away that I want proton and not IMRT. And so again, we had some discussions. I had a question from Larry, talked about PSA testing, talked about when it's the weekly PSA hormone testing, using an off-label agent. Yeah. PSA is low, and that's good. But what hormone therapy does is it causes your testosterone levels to be reduced, which starves and weakens the prostate cancers, resulting in a lower PSA. The cancers are still there. They're just being suppressed. So, and what you don't want to do probably is, at least with other types of hormone therapy, you probably don't want to stay on that forever, because you risk your prostate cancers becoming hormone resistant. And that's a condition that you don't want to find yourself in. from what I understand. I've never been there, but that is what I heard. Michael Wynn.
Hey, Brian, can you talk a little bit about your experience with both short-term and long-term side effect in your case?
Yes. Interestingly, I had 1 day of side effects during treatments. On my 3rd day of radiation treatments, that evening, I started having problems urinating. I did, and I'm thinking, oh my God, I went through all of this hassle to have the right treatment, and here I am, not getting the result I wanted. So I texted, or I called my radiation oncologist, and I said, here's my problem. This is what's going on. And he tells me, not a big deal. He says, with some men undergoing radiation treatments, there is an inflammatory response in the prostate, a swelling. It's not like it's getting radiation damage. It's an inflammation. And he says, if that inflammation is near your urethra, it'll start putting pressure on it and restrict the urine flow. He said, so what I want you to do is, he said, tonight, I want you to take 2 tamsulosin and then take 2 more in the morning and then see how it is after that. So I took 2 right away. I took 2 more that morning. And by the next afternoon, I was fine. And I have not had the problem since. And so what I had done is I had already gone ahead and canceled that next day's treatment, because I'm thinking, if this is best that's going to happen, I'm not going to want any more of this. But as it turns out, he was right. We picked, so that was Monday, Tuesday, Wednesday. That 3rd day of treatment had problems. I canceled Thursday's treatment because I didn't know what to expect. But by Thursday afternoon, I was fine. We picked back up again Friday, and I had no other problems going from there on. So that was my one short-term experience. Long-term, the only side effect that I've had, and this happens, everybody knows this, you kind of can't avoid radiating the seminal vesicles. It's like damn near impossible. And so retrograde ejaculation, I think they call it. It happens. It's not a big deal. I mean, I'm 70 years old, not going to have any kids anymore anyway, and so that's nothing. But besides that, side effects, none to mention.
Congratulations, Brian.
Yeah. Yes, Ed.
Hey, Brian, I wanted to make 2 comments on what you talked about. One is you said that active surveillance bought you time.
Yes.
And the real advantage of that is that from the time you started on active surveillance until you went to treatment, there were 5 or 6 at least different kinds of treatment that came on the market and were made available. And that to me is the learning about how valuable active surveillance is. I've been on active surveillance since 2017. So I'm in the same kind of time frame. And the things that have happened since I joined this group and started following it are just amazing. Proton therapy was not there. You didn't have that option.
Yeah, not here anyway. Some places, yeah, but certainly not here in Ohio. At least not in, not near me anyway.
Yeah, exactly. And so many other types of treatments and the existing treatments have improved significantly. So that to me is one of the best selling points about active surveillance and for guys to look at that. The other thing I wanted to share was, some of you know I'm an attorney and I work in the area of estate planning. And one of my colleagues came in today and said, hey, I've got a guy that's doing a will and he wants to do this and this and this and this. And I said, this seems kind of strange. And she said, well, he just found out he has prostate cancer and he wants to make sure everything is taken care of right away. And, this is a guy that's scared to death of prostate cancer and he doesn't need to be. And so I said, look, here's my card. Give him my number, give him my card, tell him to call me. I would love to hook him up with our prostate cancer group here in Cincinnati and make sure he gets all the knowledge he can before he makes a decision about what he's going to do. But, my concern, of course, is that he's so scared he's going to run out and, he's probably with the urologist, and you know what's going to happen. He's going to be getting surgery and living with all the outcomes.
Yes, and even in his case, it depends. I mean, some people get that with a Gleason 6. Now, if he's got Gleason 10 with cribriform pattern and intraductal carcinoma and all these, things that you've heard about, there's a little more reason to be concerned about that. But for if he caught it early, or not even early, just a lower scoring system, and treatments today are so incredible. Whereas I had monotherapy, just Eligard by itself. There's doublet therapy now. You have both ADT and an RP put together, and sometimes triplet therapy if you're in that. I mean, there's so many things. Pluvicto wasn't there when I was treated. In fact, Spacor wasn't there initially. Spacor was FDA approved in 2015. The Spacor View that I had was approved in 2019. Again, so things change so much, and the medicine, as long as there's funding there for this research to happen, these great things can occur for us that will really give us tools to use if we get in a bad situation. And I just have been really impressed by, again, I hear things from you guys so often, experiences that you've had, that I do keep in my notebook, sort of, that just in case my numbers start going up, I'll have this to look towards. But yeah.
Well, I participate in the prostate cancer research group, and I can't tell you about all the things that are out there, but I can tell you that there's research going on in areas that is going to take prostate cancer to a whole nother universe and provide so many more different kinds of treatment and more specific kinds of treatment that surgery, I think, will become, a very, very seldom used type of treatment.
That's one of the things that I had to work through also. We hear this a lot these days, that if you do radiation first, you can't do surgery later, or it'll be more difficult. That if you do surgery first, you have radiation as an option. And what I found out in recent years, there is some truth to that, but the full truth that if you have radiation and there's a recurrence, half the time recurrence is distant from the prostate. So it's a different set of treatments for that. The other half the time, depending upon the nature of the recurrence, you can have focal therapy like cryo. You can have brachytherapy, because where you put the radiation is more controllable. With like brachytherapy, SBRT, you're controlling where it's gone. In fact, you can even do radiation sometimes, as long as you're careful about how much radiation hits the rectum. You really have to make sure rectal tissue is very sensitive to radiation. And so it wasn't a factor of having radiation and I can't have surgery. It's if something happens after radiation, I have 4 options before even surgery is even considered. And by then, I'm 70 years old right now. If things take 15, 20 more years, get hit by a Mack truck anyway. So these types of things. So it's really just doing what you think is best for yourself. And again, not letting that fear take hold. Fear really messes up thought processes. And let the numbers guide your treatment. That's what I did. And so far, so good. My wife thought I was crazy at first, active surveillance, but now she's a huge advocate of it. When she hears things, celebrities like the defense secretary earlier this year, I think it was, or maybe last year it was, prostate cancer. And, she'll ask those questions. Well, what was his Gleason score? What was his PSA? What was his MRI? What was that called for to have surgery right away? Was that necessary? She really understands that. And it's good that this is getting more and more out there for more guys that they hear about, and hopefully, start getting tested early, 45 years old, and annual testing, and just keep going with that. Any more questions out there?
Ryan, you're obviously going to a lot of different groups. This Reluctant Brotherhood is an example. Are there some other groups that you visit during the month or that you'd like to
Yes.
share?
Yes, Mayo Clinic has a great one. Duke University has a good one. I go to the one at Wright-Patterson Air Force Base, which is right near where I live. Miami Valley Hospital in Dayton, both their hospital and their South Hospital have in-person groups. And I'm regularly attending webinars. Each month, the first day of each month, I go into Eventbrite. That's that online meeting scheduling app out there, Eventbrite, and I type into their search tool there, prostate cancer seminars this month. Now I want one that's English speaking because I don't know any foreign languages. I do some filters in there, and usually there's 2 or 3 webinars each month, usually out of the UK, which I think there's a 5-hour time change there, something like that, but it's not a big deal. But so it's not just support groups I attend, and I listen to those webinars that are online, and I ask questions there. I mean, like one of my big questions, whether I'm in a support group or those webinars, is right now I'm testing my PSA I've just moved to 6 months. Every 6 months it'll be now. Is there something else that I should be testing besides PSA? Is there some other metric that will give me insight into my status besides just, and typically the answer is no. PSA is the gold standard. Once you've had treatment, check that regularly. And I've already had genetic testing. I've already had genomic testing. They say that's it. So that's what I'm going with. But yeah, so I'm probably attending 5 or 6 support groups each month, plus 3 or 4 webinars.
You mentioned that PSA was the default factor there for most people. I was listening to a video today that was put together by the Association of Urologists, what AUA is what it is, I guess it is. And they had the group that's actually sets the NCCN guidelines. And one of the things that came out of that was that PSA velocity didn't stand up to the testing or to the statistics of what they're supposed to do. So I'm looking for some more backup to that, but I thought that was kind of a strange thing because for years and years that was the one thing everybody always said, that you got to watch your velocity.
Yeah, and so what my medical oncologist and I have done, she's been the one controlling, she's the one who scheduled my hormone therapy. She schedules all my blood work. Been doing that for almost 4.5 years now. What she and I are doing, we don't look at PSA velocity. We sort of look at PSA doubling time. What we do look at is my PSA nadir, and to see how above that it's going. My PSA nadir, let me see, right after my treatments, due to my Eligard, my PSA was 0.008, and it stayed that for 9 months. And then once the Eligard started leaving my system and testosterone started coming back, my PSA went to 0.198, and that we consider my nadir right there. And so it's been slowly going up. Right now it varies between 0.35 and 0.55, but we're 4 years later now. I mean, we're sometime later, and it stays in that range. But what she has said, though, she has said, if you ever have 3 successive PSA increases in a row, we're doing a PSMA PET scan on you. So she isn't so much looking at the doubling time, unless it's clear that it's bad. But she's looking at 3 successive increases in a row in PSA. And that's something that she and I have worked together so well. Going into my treatments, when I left active surveillance, I told her, even though because I stick to numbers, sometimes numbers can drive me crazy. I said, is there any way that we can relieve my anxiety by giving me a PSA test right before treatment and then right after treatment so I'll know how things are going? And she said, sure. So 4 days, right before that first Eligard injection, which was about a week before I started treatment, we had a PSA testosterone test right then. And then when treatments ended, we had another one. And that was 0.224. And I think I showed that in my, chart there, that 0.224. That was the one that we did right at the end of treatments there. And that settled my mind, relieved the anxiety that things were going in the direction that I wanted. And then the very next one was 0.008, and those were really cool. I liked those next three. And then what happened was in late January or early February of 2022, I recall telling my wife that I think the Eligard is wearing off because I'm starting to lift heavier weights in the gym. But I wasn't due to another PSA test until April. So I went down to CompuNet, scheduled my own PSA testosterone test. That would have been the first part of February of 2022. And sure enough, my testosterone, which had been down to 3, was up to 403. And my PSA, which had been at 0.008, was 0.13 at the time. And so again, all these data points helped me feeling good that things are going like I had hoped. And then the April 2022 PSA test, that my official test, 0.198, that was that official number, my nadir, and I also showed those stopping finasteride, stopping testosterone. After my treatments, I wanted to make sure how things were going after the radiation. But if I did the radiation and then stopped finasteride right away, if something went wrong, I wouldn't know what it was, the radiation or the finasteride stopping. And so I waited almost a year until after my treatments were done, or quite a few months. I was about 9 months later, something like that, or what is that, 2 months? Yeah, 2 months. I waited some time before I stopped the finasteride. And once I was satisfied that I was doing good, and much later, I stopped at tamsulosin. And again, I kind of, that scientific mind in me, I do things in sequence. I want to make sure that I don't muddle the waters with two things that might be happening at once. And again, so all these things related to PSA that are out there, I worked through it with my medical oncologist, and she's been great. Very explanatory. If I have a question, she's right there. There was one time when she couldn't be there because she was doing rounds. I guess doctors still do rounds these days. And she had a nurse practitioner come in to see me who was just as knowledgeable, just as great. And so I've had a good experience there.